Thank you very much, James. And it's great to see so many people here again. And I think my job is first and foremost to welcome you to ABF Conference 2016. Can I also welcome particularly my fellow Pricing Authority board members, particularly Jim Birch and the others. Many of you will not be aware, but we have regular meetings where the board members have to plough their way through about 1,500 pages plus of documents. I blame that on the consultants that are here today for giving us such long reports, but I can tell you that they read them and they're very influential in our decisions. I don't know about you, but I find myself constantly thinking about what motivates people, what drives people. Sometimes I think it borders on some sort of sick psychological voyeurism or something. But I'm guessing that if you're here today, then there are probably a couple of things that motivate you apart from your pay packet. And one of those is that you want to do something good for the community. I think that's a fundamental, and it's very interesting working in a commercial world. It's not as strong a driver, not surprisingly. But secondly, I think we work very hard and we try and do something for the community, and what really matters is when that work is sustainable, when it lasts, it isn't dissolved at the next political whim. So what I want to do this morning briefly is reflect a bit on ABF over the last 4 years at a national level and try and give you some insight into why I think it's being sustained, retained, and also what we need to do in the future to keep it up to date. So I got James and the team to drag out the COAG members of February 2011 when the National Funding Agreement or Memorandum of Understanding was first signed. And for those of you that can look carefully, you'll see one person who is left standing. We've had a few more Prime Ministers since then. In Queensland, we've had a couple of Premiers. If you look at the group now, there is only one person left standing. It's Colin Barnett from Western Australia. But somehow, activity-based funding has survived. I think the decision by COAG, First Ministers in April 2015, is in many ways more important than the first decision to introduce national ABF. It's important because you've got a whole new set of First Ministers who've endorsed the work that we and you have all done over the last 4 years. They would not have endorsed it if it hadn't been successful. And of course, we'll all have a version of what success is, but I think I know what failure is. But success, first and foremost, is it was intended to reduce the growth in costs of healthcare, and particularly hospitals. And that in itself makes hospitals sustainable and avoids draconian measures that might make hospitals less accessible. So in terms of cost per NWAL, the national costing studies that I'm sure many of you labour over, we've seen a dramatic levelling out of costs over the last few years. Growth rate pre-ABF, and I have to admit a couple of years pre, to what looks like a sustained growth rate of only about 1.1%. Translating that into national efficient price, we're actually seeing the price go down. That might be very scary to people in hospitals, but it is the large indicator that ABF has been successful in at least controlling costs. And I think that's probably the most influential reason why the Prime Minister and Premiers decided to retain ABF nationally into the future. The fear, and in saying that I should also mention that there are a number of senior public servants in Canberra, and I pay credit to Martin Bowles particularly, who saw ABF as something that is worth retaining, and remembering that it was to be stopped in 2017 as a form of national funding. So I pay a lot of credit also recognise the work that was done in Canberra to retain what the public servants saw as a successful initiative. The fear was that with activity-based funding, that activity would go out of control. My personal experience in that is it hasn't happened and never has happened. But you can say in the very early year, the first year, I think as people coded better, then we saw a significant growth in acute admitted activity around 4.5%. Since then, it's been very, very low, 1 to 2%. So if you combine, effectively costs going up very marginally with activity going up very marginally, you're looking at 2 or 3% growth in hospital costs, complexity adjusted. Compare that with private health insurance, which do combine price and activity. We, I think, and thanks again to the work that you've all done, have succeeded. So why has it succeeded in at least those raw indicators? I think, first of all, it has been a great example of how the Federation can work, how the Commonwealth and the states can work together to get a great outcome. Remembering that ABF was introduced at the time we started our work, only Victoria and South Australia had ABF. So to implement the system state by state, and to implement it so well, I've got to say, so sensitively, not trying to blow the world up, but transition into the new system, is quite an achievement. I always think of ABF as simply a tool. I have a car and I don't know how to use most of the things that are in it. We also have a Thermomix at home, actually, and I can do soup and that's about it. But they tell me you can do a lot more, and I think ABF's a little bit like that. What you can do depends on your skill in using the tool, and it's fantastic to watch across the country how people have not just conceptualised as activity-based funding, but about activity-based management, about how you commission work, about how you incentivise certain behaviours, about how you make the data that's available nationally and at a state level much more transparent, so people can see where it is they might be doing well, where it is they might have areas for improvement. Every state, in my view, has made significant progress. Perhaps my one disappointment is that the only state not using the national classification system is Victoria, but in saying that, I would acknowledge that Victoria has dissolved a number of specified grants and in a sense returned to a predominantly activity-based funding system. So I think the success is primarily around the way that Commonwealth and State have worked together. There have been some interesting times, it's not all been smooth. We've taken the approach from the outset that we're on about transparency. We give states our workings, and one of the reasons for that is that it's not just that we want them to believe we haven't played a trick in some database somewhere. We actually want states to check that we've got it right. And every year states have come up with areas where we haven't got it right. So in a sense, states have become IHPA's quality control mechanism. That can sometimes be embarrassing, like one of the health ministers saying in Parliament that he was doing our job for us. But it is a very deliberate approach to make sure we've got it right, and also to engage states. So I think at the level of officer level, there's been tremendous dialogue, tremendous challenge, and we appreciate that. Of course, if the Commonwealth Government does something, state government does something, that doesn't mean anything happens on the ground. And I think what's exciting about this particular conference is we hear about the ways in which people have examined things like clinical variance, engaged with clinicians, engaged with the data, improved the coding and costing so that the system is credible. And this has happened extensively across the country. That micro work at the hospital level, at the ward level, has been part of the success. So that's great, but if that's all we do, then we'll probably end up ossified in a very old system. So what we're interested in now is what's next. How do we keep activity-based funding modern and leading the world, or at least up to date with the world. So I just want to go over a few areas that are high priorities for us at IHPA at the moment. One is a mental health classification system, and this is a very important piece of work for two reasons. One is that there is a general recognition that diagnosis alone is an inadequate predictor of resource consumption in mental health. So at the segment level, you know, whether it's acute, admitted or community, without adding other things like functioning and levels of social circumstance, then we won't get an accurate classification, nor will we get something that will be acceptable clinically. So we have version 1 and have, you know, a higher level of engagement with the mental health community as a version 1. There is no doubt it will improve over time. Our first step is to introduce it into the admitted setting. So the first reason for the mental health classification is that we want it to be clinically relevant, to take into account the real situation of people with mental illnesses beyond diagnosis. The second reason is that we recognise that that the strength of the community sector in mental health, and that is not the best system to be paying for individual visits. So can we move to a bundled approach, at least outside in you know, when phases of care are at least vaguely stable? Can we move to a situation where we can bundle care in the community? That's a very exciting piece of work. We will need to do a lot of adjustment, and we welcome feedback on it. The impossible task we've set ourselves, or the task that was set for us in the agreement, was to do something about teaching, training and research. I said to Tony Sherborne when he started, I said, it's impossible, you're never going to be able to do that. And he's kept that belief that he can. James continues that belief. Why is it important? One, it's a big number. $1.5 billion is spent on training and research. Two, there is a very high level of variation between states. If you look at this table, you're looking at Victoria with $49 per capita compared to WA with $98 per capita. We don't know whether that's an accurate reflection or whether the same definitions are being used. This is a block funding amount at the moment. It's material enough to influence the actual ABF amount that we pay. So we're very keen to come up with a classification of some sort that introduces some fairness into the allocation of teaching, training and research. Third, we are very interested in promoting the use of the fantastic data that you're all involved in collecting. New South Wales, without doubt, has led the country and developed a fantastic tool that allows people to benchmark and manipulate the data in very easy ways. And so we're working with New South Wales to extend that tool across the country, and I think this is part of our transparency agenda. It's part of how local people can use the data and not have it locked away in complicated spreadsheets. Fourth, an outcome of the First Minister's agreement recently is that ABF has to move its way into safety and quality. And we've noted over time a number of very good thought leadership pieces, and I acknowledge Professor Duckett here today, that have called on us to do that. We have been ambivalent, and we've been ambivalent because we don't interpret the agreement that we work under as us leading on safety and quality. But things have changed. One is First Ministers have said that this has to be incorporated into ABF. Second is that you're seeing across the country a number of states and private health funds that are starting to incentivise, reward, punish behaviour around safety and quality. We've been for a couple of years, I guess, seeing this coming and preparing with the Australian Safety and Quality Commission some work on what would be foundation data for this. So we took the CHADEX work and narrowed, with clinical input, narrowed it down to about 40 hospital-acquired complications that we believe, and the Australian Safety and Quality Commission believe, may be preventable. Whether it's 100% preventable or whether it's some reasonable benchmark or standard. But the challenge that we have, I think, over the next year is to work out a way of doing this that achieves the right outcome in terms of price signals for safety and quality. We've also been looking at bundling, and we've taken, I think, baby steps in this direction. If you think about what case mix was originally and what DRGs were originally, they were bundles of costs accumulated while a person was in hospital. To keep ABF moving forward into a modern era, we've got to recognise that really the focus of healthcare is on chronic illness, on people that continually use services. And is it possible for us to move away from a purely episodic model to a model that can encapsulate the chronic conditions that dominates resource use in healthcare? We're well positioned to do that because part of our brief is not just to fund within hospital services, it's to fund hospital services, and hospital services has been one of our great challenges. How do you define a hospital service if it's not something that happens in a hospital? But again, with good collaboration, we've managed to do that, and the agreement, first one and the current one, reiterates that part of our role is to keep people out of hospital. And so can we work towards a bundled pricing mechanism that incentivises that? This is a great challenge because the level of clinical variation, resource use variation is very high. At the moment, we have dialysis and ventilation as a bundled payment. We're working on maternity services, but I think there are many more areas that we can look at. Finally, we're looking at the non-admitted classification. I think our non-admitted classification was introduced as a temporary measure. It's clinic-based, not patient-based. The idea of activity-based funding is that it should have a very strong, if not total, component around the characteristics of the patient, not the characteristics of the care provided. So we are working on this, and I think this will be a very important next step, particularly as outpatient services become a bigger and bigger issue across the country. As I move around, people are constantly recognising this hidden waiting list. So some proper incentive around the non-admitted world is quite important for our next step. So these are all big pieces of work that need to be done, and I reiterate that they can only be successful in a collaborative, transparent, healthy dialogue culture, which I think we have created together. It's not always pleasant. We strongly disagree with each other, and I'm sure you strongly disagree with what we do from time to time, but our modus operandi is to have the debate, be open, assess the arguments that are given to us, find some data that either supports or doesn't support the data, the argument. So in closing, can I just also acknowledge the work of IHPA, Tony before James and James' team. There aren't many people in IHPA. I think there are 50 altogether. They work their butt off. As an authority, we think very highly of the work that we get. It's well researched, it's well written, it's gone through an engagement process, and there is a healthy debate that occurs at the authority meeting. So, but that can only happen if we're well serviced, and so because I won't have a chance tomorrow, can I just thank the staff that organised this and the staff that have worked so well over the last really 4 or 5 years to introduce this. So thank you again. I'm sure you'll learn heaps from the conference. We've got some great speakers, and the workshops are really interesting about how people have used ABF. We look forward to working with you in the future on these still big challenges that are ahead of us that will take ABF forward. So thank you very much, and enjoy the conference.